Well, many of you will know Peter Greenhouse. Peter and I were at Cambridge together many years ago, and we had quite a riot each time. And Peter contributes to our menopause supervision MDTs on Sunday afternoons. You'd all be welcome to join them on a Sunday afternoon on alternate Sundays at 4:15. So the menopause people who are studying for the advanced menopause certificate, some of them have already got it and some of them are here, and Peter always contributes to that as well. He's going to round off this morning by looking at hormone replacement therapy as primary prevention. So I think that really ties in very nicely with the theme of the morning.
Thank you very much, Karen. It's an absolute delight to be here as a presenter, not just for the best croissants in London, but also because it's just a wonderful meeting and lovely environment. It's also lovely to be back with Karen performing yet again. And we've got a few little technical glitches here, and I never get stage fright. I only ever get tech fright that the stuff isn't actually going to work. Now, one of the challenges that you will probably have worked out is that the new NICE guidance only appeared 2 days ago. However, that is all worked into the presentation, you'll be pleased to know, because I happened to be in Paris at the time of the GEMBI meeting, which is the French Menopause Society meeting. We had 2 days there, and some of the stuff was relevant to me, and some of it wasn't. It's very interesting that in France, the gynecologists do all the breast surgery.
Yeah.
And also they take much greater care for cardiovascular disease, because essentially once they've taken over menopause management, they become the GP for the patient. So it's a much more holistic approach to that which we have here. Very interesting and very entertaining, and I learned an awful lot, but I was also fiddling about with the presentation in the background at the same time. So, are we nearly
there? No.
Are we nearly there yet? As they say. Well, another minute. Oh my goodness! Without hesitation, deviation, or repetition on the subject of menopause. Well, there we go. Fine. I think we're just about ready to roll, or maybe not.
Yep.
Right. Well, let's go for it. Okay, so I think this is arguably a very, very challenging subject, particularly because the NICE guidelines has just come out, and will tell you almost the opposite of what I'm going to tell you. So I'm actually taking to task the NICE guidelines in this presentation. Thank you very much.
After you.
Is it on the screen yet?
It will be.
Oh,
Victor?
press a button, and here we
There we
go.
are.
Ah, right, we can start now, at last. And I've just got to make sure this is going the right way around. So, how should we think of HRT as primary prevention? Because this is absolutely not what NICE wants you to do. It's also not what the International Menopause Society wants you to do, not what NAMS, the North American Society, wants you to do, or indeed the British Menopause Society wants you to do at the moment. Let's see how it goes. I've got some declarations here, actually. I pressed the wrong button, as ever. Life's all about pressing the right buttons. So, lots of different declarations for various different HRT firms that I've worked for, but none of this is promotional. More declarations in the sense that this isn't the first time I've given this talk. This is 2 weeks ago at the Mexico annual ONG conference. And also, I did it at EMAS, where we were looking very specifically at the graphic design and the presentation of information and how to make that information more easily accessible. And also, well, that hasn't quite worked. I did the Lenzetto launch in India in July this year. So I've been doing quite a lot of teaching in different formats using the same material. Also, my declaration that we now go back 50 years.
Oh, that's very embarrassing.
Moving on, okay. And another declaration, my only conflict of interest is with the government of my own country, which is why I retired and moved to France to escape Brexit. But anyway, there we go. So let's get on with the show. Oh yes, this was also something that I did for the B a little while ago, and for the RCOG. And you can see we've still got a problem, although perhaps not quite as acute as it was when we couldn't get Nutrogestan and other things. So, I'd like you to take a look at the whole woman if you're going to consider a holistic approach. and we think that we, you know, as to what doctors can and can't do. We have no control over the winds of fate, if you like, but we would like to throw a protective blanket around our patients. But it's not as easy as that, because there are so many things that can go wrong, and we have absolutely no bearing on any of these intersectional disadvantages that these women may have when they come to see us. Also, we can do something about some of these issues of their milieu or their environment, and in fact you can almost say that it is an absolute responsibility, which we mustn't shirk, to deal with lifestyle, nutrition issues, and get them to stop smoking and take less alcohol, etc., etc. But the bits that we were actually quite good at are the other side, the medical side, the various different systems that we can improve if we use HRT. And that's what this talk is going to be about, I hope. So if we think about it, the big question, here's the big question. Are you just going to sit there in your surgery and wait for the woman to turn up and treat each individual symptom that they present with a different drug, not a non-hormonal drug that's very specifically related to that system? Or are you actually going to take the bold step and be proactive, preempt the problems you know are likely to happen, and actually get ahead of the game and do what GPs are supposed to be quite good at, which is preventive medicine? So that's what we're going to aim for. So if we think now about testing your knowledge, and this is going to be a show of hands, I want you to think about this question, because when I showed this question to 500 gynecologists in Barcelona, not one of them got it right. And when I showed it to 300 gynecologists in Mexico 2 weeks ago, only 4 got it right. So, suggest the question, and then we're going to have a show of hands. Right? This is going to be because I want you all, okay, people can put their hand up for not knowing the answer. So you have to work quite hard at this one, because some of these are actually quoted from the NICE guidance from 2015, and I haven't adjusted it since that time. So I want hands up for 1. Risk of having a heart attack is minimally increased. Any hands up? 1 hand up. Okay. What about risk of dying from a heart attack is not significantly altered? Oh, lots of people on that one. How about the risk of dying from breast cancer substantially reduced? 1, 2. 2 people. Was that a third?
Yeah.
3 people. That's very interesting. Okay, but a bit of a challenge there. What about? Oh, sorry. Let's go back to that previous question. Risk of bowel cancer slightly increased. Okay. What about the risk of osteoporotic fracture being slightly decreased? Yes, that's. So we've got quite a few hands up for that. So the 2 most popular answers are number 2 and number 5. And I'm not going to give you the answer just yet, just for the fun of it. Okay, so now we now have this, oops, get it the right way around now. Here we go. So we now have NICE published or announced 2 days ago, and this is one of the points that they make. It doesn't increase the risk of coronary heart disease and doesn't increase cardiovascular mortality. Which is interestingly what they actually, this is what they said in the previous guidelines, but they said it did slightly increase coronary heart disease in the previous guidelines, but not in these guidelines. So that's interesting. They're taking notice of different studies. What else did they say? Oh yes, don't offer estrogen for primary or secondary prevention of cardiovascular disease. That's, there are several other things that they've mentioned. Which we can come to in just a moment. But what do we know before 2002, before the big disaster of the Million Women Study and the Women's Health Initiative? Well, we know all of this stuff. All of that. There's enough research to back up all of these points here. And the bottom line, perhaps, is that if you have a 1/3 reduction in all-cause mortality. So my big question is, in what other field of medicine would you ignore a treatment that gave you a 1/3 reduction in all-cause mortality? And why on earth could we not use HRT to achieve the same effect? Now, the NICE guidelines tells you not to do that, but you will get better all-cause mortality and obviously a far better quality of life if you do use HRT. So that's the challenge. And this, if you like, is a new consensus that well, it's not that new now, it's 7 years old, and these are, each of these, we know John Stevenson here, particularly from this country, but all of these are very senior people, some of them major researchers in the WHI, who of course did not sign up to the first WHI paper. Remember, that was not written by the principal investigators. And so these people are now thinking that it's time to use more HRT for a prevention strategy. So let's think about where we're going to go. Yes, let's say you're not going to do a prevention strategy. You're going to do what most GPs do, and some gynecologists do, which is this so-called reactive polypharmacy. Now, there's no actual treatment that improves cognition except for estrogen and possibly testosterone as well. If they can't get to sleep and you're not using HRT, then you're going to get addicted to hypnotics and sedatives. And don't get me started on SSRIs, for God's sake. How many of you, when you're about to prescribe an SSRI to a woman, will tell her, or will counsel her to say that there's a 70% risk of anorgasmia? Hands up? No, didn't think you would. Or one person does. Okay, jolly good. Well, if you had that information given to you, would you take it? I think not. So what about cardiovascular? Well, you all know a lot more about managing cardiovascular disease than I do, but if you aren't going to prevent the cardiovascular disease in the first place, you're going to end up using an awful lot of stuff. You're going to get more type 2 diabetes. The genitalia are well worth an entirely separate lecture, and bisphosphonates really are not that useful at all. You may need anticoagulants. So your bottom line there, once again, is more visits to the GP, more cost, and inadequate treatments. Your random polypharmacy. So let's think that is actually the nice advice at the moment. You are advised to offer random polypharmacy rather than HRT in this scenario. So I'd advise you to stop it, but let's see if we can prove why. Okay, so this actually, I borrowed a slide from Martin Burkhauser, one of the top Swiss gynecologists and menopause experts, and this is from EMAS in Florence earlier this year. And this is the excellent study from Saral's group, looking at the fact that they estimated a rough sort of back of an envelope calculation that 58,000 women had probably died that shouldn't have died if they'd been given HRT. For those who've had hysterectomy, this was estrogen-only replacement therapy. So what does that mean? So there's more cardiovascular deaths and more cardiovascular disease, and also obviously more osteoporosis and fractures if you don't give HRT. What other risks are there? Well, we can come through these in detail, but we don't have all day. So I'm really going to concentrate on just a few of these risks. But this, once again, is the bottom line is that you have higher mortality, lower quality of life, and JDV, which is, for our French speakers in the audience, joie de vivre. Okay? A much better monitor, if you like, than quality of life. So, this is a very interesting risk-benefit assessment, actually produced by the Endocrine Society. I'm sorry that the reference is missing off the bottom there. It might be on the next slide. But this is looking at the various risks and benefits of all these different conditions, and I wanted you to get this into some sort of sensible perspective, because what we haven't got on the picture at the moment is vasomotor symptoms, mood, and vulvovaginal atrophy, which of course are major things that benefit from treatment. So let's just have a little look at putting it into perspective. So that's, oh yes, sorry, that's the original. That's what that slide should have looked like. So I forgot to take the other one out. And let's have a look at this slide now. We have risk benefit. Realistically, what I just showed you scrunches into this area here. Whereas if you take 1,000 women, then 900 or so, between 8 and 900 will benefit from improved vasomotor symptoms, vulvovaginal atrophy, and probably there's a rough calculation, about half of them, just more than half of them, will have better mood and quality of life. So all the things that NICE are worried about are in this lot here. All the things that you're worried about as GPs, all these extra relative risks and whatever, are in this tiny little bit here. Whereas if you're looking at the whole woman, there are some tremendous benefits. You really need to elucidate them all for you, but I just wanted to show you the proportions. So let's have a look at the safety and the safety issues. We're going to go for breast, well, and also for veins. I think we better start with breast. because basically this is the major feature that this current iteration of NICE doesn't seem to cover particularly well. In fact, it gives counterintuitive answers. So let's have a look at there are several different classic papers that I'm going to put together and try and knit them together in a sensible way. The problem is that you show the data, some of them have got data only, which you have to translate. Others, and this is the classic study, which was deliberately left out of the Oxford Collaborative Group analysis, and I was speaking to the authors yesterday about how their paper was not included in Val Beryl's work, and we still don't have a proper answer for why that happened. And also, of course, this is the one very useful piece of information from WHI, and you have to look very hard to find it. So let's actually show it in a bit more detail. This is the classic French E3N study of the Education Nationale. It's all the teachers being followed up through menopause, and it shows that there's no excess risk of VTE, breast cancer with progesterone or dydrogesterone, but with any synthetic, you get this substantially increased risk. What about another paper produced at almost the same time from Finland, showing exactly the same, but showing the different progestogens. They didn't actually use progesterone, and they didn't have micronized progesterone available at the time, but a British paper that came out last year, a very large case control study, 43,000 women versus 430,000 women in the control group, showed exactly the same thing as the French study, and I think that's enormously significant. That will be shown beyond reasonable doubt that it's the progestogen that matters. It's the human progesterone or dydrogesterone, which of course is the stereoisomer of human progesterone. So let's just look at WHI as a matter of interest. Let's see what NICE have to say. Does the type of hormone taken affect these risks? They say it's not known whether the preparations containing micronized progesterone or dydrogesterone have a different increased risk of breast cancer compared with other preparations containing other protestogens. Isn't that a beautiful, an absolutely beautiful typographic error? Well, that's manifestly wrong. Okay, so I think we can throw that out of the window. Let's move on a bit. Oh yes, this is WHI, and of course just showing the brilliant effect on breast cancer of estrogen, conjugated equine estrogen versus MPA. And if we now look at that in a little bit more detail, because I do admire the way that the Americans present their data, but you really have to cut into it to find the useful stuff. And this is it. There's this tremendous difference between estrogen only and estrogen plus synthetic progesterone in terms of the risk of breast cancer. And what does NICE have to say about this? Well, it says here that estrogen-only HRT slightly increases the risk of breast cancer compared to not taking HRT, whereas arguably one of the best RCTs ever performed on the wrong population actually shows that it almost halves the risk of breast cancer. Now, I shall leave you to work out what we should do with that information. Something I want to throw in just for the fun of it, just for the pure pleasure of it, is the effect on Alzheimer's disease, which is also really quite impressive. So using the worst HRT in the world, conjugated equine estrogen plus MPA, gives you a substantial reduction in death from Alzheimer's. Interesting, isn't it? Okay, what about breast cancer survival? Oh, sorry, question here.
No, I was just saying the slide wasn't moving on Teams, it is. The things didn't come up.
There's no problem.
It's okay.
Okay, well this is an app, it's done on an Apple, so that it might not work on Teams, I'm sorry.
The slides are moving.
Okay, fine. So this survival data has been known, well in fact this is now 25, 26 years old or thereabouts. And you can see there's an enormous difference in survival for those that are on HRT at the time of diagnosis. Now, some people have said, and I might want our breast surgeon to comment on this, that this is all very well, but these people are using HRT versus people who are not taking any treatment. Maybe it's just a healthy user effect. So is it genuine benefit? But let's just be cautious about this and say HRT is associated with better breast cancer survival. Okay, that's once again, it's quite counterintuitive, but it is true from this graph. And nothing much has changed at the time to change that. But what about the Finnish data? Let's go into it in detail. And this is a fantastic study because the Finns have got tremendous record keeping for their entire population. So let's look at the 50 to 59-year-olds and what happens to their risk of breast cancer if they're taking HRT. Oh, look at that. It's reduced by 2/3. Halved if you're in the 60 to 69 age group. And it's only reduced by 1/3 for the 70-year-olds and above. And if you put all that lot together, the fatality rate is halved. And I put it to you that that is too large an effect to be considered a healthy user effect. Now, what is NICE? Oh yes, I have to say about that. Well, once again, we have this same stuff from NICE, which according to this very large, excellent study in Finland, is absolute rubbish. Let's move on. Okay, so provided you don't use synthetic progestogens, there's no excess cancer risk from taking HRT. You should use body identical or body similar, which is progesterone or diprogesterone. There's much better survival if you happen to be on HRT when you're unlucky enough to get breast cancer diagnosed, and there's less death from breast cancer regardless of which HRT you are taking. Okay, time to move on to veins. Where do we go with the veins? Oh yes, well this is the classic study from France, done now 20 years ago, showing that if you're using transdermals, you have 4 times less risk than if you use oral regimes, and no significant difference from no treatment at all. And the reason, of course, for that is that there's next to no first-pass metabolism when you take transdermals. But the oral regimes all have to go through the liver, and 95% of your estradiol is converted to estrone, which only has about a 1,000-fold activity, estrogenic activity, which is why you have to take quite a substantial dose of oral estrogen. And that's why also, of course, all your coagulation functions are messed up. So little wonder that there's a big problem with oral regimes. And the same was shown in a much bigger UK study, more recently published. So this is exactly the same data, effectively, that the transdermals do much better than the orals. And there's different, should we say, different values for different types of progestogen. And the one that seems to perform well is oral estrogen plus diprogesterone. And the worst performing regime, the one that nobody in their right mind would use, happens to be the one that was used by the Women's Health Initiative. Isn't that nice to know? Okay, so as far as the veins are concerned, there's no excess VT risk provided you use transdermals, or you could use oral and progesterone, oral and diprogesterone, and oral and IUS, but I haven't shown you the evidence for that, but it's all in this paper here, and anything written by Alfred Meck, I would very, very strongly recommend. He's written some brilliant review articles. Great man, really great man. Okay, so here's another question coming up. Which of these conditions is a contraindication to taking transdermal HRT? Breast cancer family history, mother and sister, severe hypertension, severe liver disease, past pulmonary embolism, obesity, or none of the above. So, let's go around the room and say who votes for breast cancer family history? Yes, all right, breast cancer, one breast surgeon votes for breast cancer family, you have to do that, okay? What about severe hypertension? We just heard a case about severe hypertension and heart disease. Anyone vote for severe hypertension as a contraindication? One person votes?
Treat it.
Well, hang on a bit, okay. Severe liver disease. Any takers? That's, okay.
With abnormal function.
With abnormal function?
Possibly.
Yeah, with abnormal function, okay, that's fine. Actually, I should have severe active liver disease, should have said that, but I'll still challenge that. What about past pulmonary embolism? Oh, come on, surely now. Or just obesity. Oh, sorry, IMC, that's the French version, the Spanish and French version. BMI, obviously. No takers for, would you start? You wouldn't start all something of that size, would you? Okay. What about 6? None of the above. Oh, yes, we've got a few takers for 6. And who doesn't know? Come on, be honest. Several people don't know. All right. Well, let's have a look at the contraindications to starting HRT. And of course, I didn't put pregnancy here, but unexplained vaginal bleeding and estrogen-dependent cancer, obviously contraindications for both. But thromboembolic disease, stroke, aneurysm, liver disease with abnormal liver function, and malabsorption syndromes are okay to take transdermal, as indeed is porphyria, which should have been there somewhere, but I think I've lost it off the slide. And as far as the ones at the bottom are concerned, yes, give the weight loss advice, treat the hypertension, but you can start the HRT straight away. Start it straight away, because remember, of course, HRT is cardioprotective, not just in terms of its effect on the arteries, but also on the neurovascular bundle. So you'll get less palpitations. In fact, interestingly, palpitations are one of the symptoms that get better quicker than almost any other when you start giving HRT. And once again, for the older women start with lower doses. Fine, okay, and if you're really not sure about it, this is actually quite brilliant paper that I keep on still refer to, though it's now many years old. This is Alistair McLennan's brilliant paper. No conditions, absolute contraindication of HRT. If potential risk is understood, if HRT is effective in symptom control and quality of remaining life is paramount. Beautiful bit of writing. Okay, let's have a look then about what the oh dear. Sorry, that's from these are translated back from the Spanish, not completely. So this is appropriate systemic estrogen regimes. Okay, so it's interesting. The Americans call transdermal estradiol a precision regime. Now that's the regime that most of us use, whereas the Americans are obviously just getting the hang of using it, or only just starting, and because they are used to oral fixed dose regimes. What about the fixed dose regimes? Yes, fine, if you're fit, slim, young, and no VTE risk. That excludes most Americans. Certainly, sorry, most Americans in the WHI trial. And if you're able to accept, if you're lucky enough that the dose of estrogen, that you're fit and slim and all the rest, and it happens that the dose that the manufacturer has chosen in that combined product happens to be the right dose for you. Oh, also, and if you can't or won't use transdermals for whatever reason, it's interesting in parts of the world where things are very hot and sweaty, you can't use patches because they don't stay on, so it limits your options. Okay, what's inappropriate? Well, certainly oral estradiol, as we just described in older women and women who are overweight and who've got the risk factors that we've just been talking about. What about completely inappropriate would be, oh sorry, I've been trying to translate that and missed a space there. So multi-estrogen regimes such as conjugated equine estrogen, and this is Alfred Meck's paper coming up now. Think about it. There are 40 different types of estrogen component in equine estrogen, and only one of which you're really interested in, and all of which have different pharmacokinetics, pharmacodynamics. And this is actually a brilliant statement. Conjugated equine estrogen offers no advantage over physiological estradiol. Use of an estrogen extract today should be considered inappropriate. Today, 23 years ago. Now that's a long way ahead of the Americans, and almost very few people in Europe are using the regime that the Americans would use. So this is actually very enormously important in terms of looking at the divide across the pond. So this is the statement from the North American Medical Society. Treatment should be individualized using the best available evidence to maximize and minimize risks. So I've still got the Spanish translation there. But basically, why would you want to buy something for people who are still trying to sell you these old hormonal regimes? I mean, why would a Brit, or indeed, when I was doing this slide, why would a Mexican do anything that an American told them to do, for God's sake? So, we've got here many other different benefits that we need to talk about, because we've talked about the safety for breast, safety for veins. It's now time to go on to some of the other issues, to talk about heart and also about cognition. It's about time we talk about heart attack, because remember, of course, that HRT prevents heart attack, which of course is the opposite to what the headline news actually said all those years ago, the day after the paper was first published in that august medical journal, the New York Times. So let's have a look and see what Tommy Mikkola's group in Finland come up with, again, looking at the substantial reduction in cardiovascular mortality from women who are starting HRT under the age of 60, and that's quite brilliant. There's almost a 50% reduction, or anywhere between 50 and 60% reduction. And you still get a reduction if you start later. And look at this, isn't it amazing? You still get a reduction if you start HRT at the age of 80. I mean, it's not much of a reduction, it's statistically significant, but probably not clinically relevant, and you wouldn't want to start HRT then. But I would look at this area here and say that there's a very substantial reduction. And that reduction's interesting because they said you get a larger coronary heart disease mortality risk reduction the earlier the therapies are initiated. So what's the punchline? Is start early. And and that's what we learned from the previous lecture. Now, what does NICE have to say about this? Combined HRT does not increase mortality from cardiovascular disease. Well, that's technically true, but I think under the circumstances, given the very substantial reduction that's been achieved in Finland, that's a little bit disingenuous, and we should also throw that out of the window. Can you see where we're going with this? There's a sort of thread here. That shouldn't be there, but actually it seems it happens to be there. It's from Martin Burkhauser's talk in Florence, showing this timing, so-called timing hypothesis, which was very elegantly demonstrated by the previous speaker. So, what about this classic RCT of oral estrogen, which we wouldn't, once again, normally use as a first line? This is by the Danish group, and they stopped the trial at 11 years because of WHI. But one of the great things about this RCT is that the endpoint's quite robust. I think you'll agree that death is a pretty robust endpoint in any study, or admission to hospital due to heart failure or myocardial infarction. So when they continued this, they continued to observe the patients after they'd stopped treatment, and what they found was a faster rate of decline in those who had previously been on the treatment and then stopped, and therefore raised the question as to whether do you actually increase the heart attack rate if you suddenly stop HRT? And yes, you do, because Tommy Mikula's group come in with these brilliant figures to show that you double or increase by approximately 1.5 your risk of myocardial infarction if you actually suddenly stop HRT. So the news there is don't stop. Once again, that's the opposite of what NICE would have you believe. Okay, so here's the punchlines, if you like. Start early to prevent atheroma, keep going to preserve function, don't stop so that you don't just kick the bucket. Right, so let's see which of these, which was true. So the actual correct answer is this one. And it's, once again, that is completely and utterly counterintuitive. Very few GPs know that. No gynecologists in Barcelona knew it, and these were an international audience, which I'm just proving to you just now. This was an Gideon Richter sponsored meeting. So this is what the NICER guidance might say, and this is NICER, the Non-Biased Interpretation of Healthcare Evaluative Research Institute, that you can join. I've just founded it last night when I was fiddling about graphically. But these statements are true. Having heart attack is substantially decreased. Dying from heart attack is decreased. Breast cancer is halved. Bowel cancer, as you already knew, was slightly reduced. And osteoporotic fracture is actually approximately halved. So that's what I would like the NICER guidance to say. Oh yes, and also you can read that for yourself, and we'll put that up at the end. Somebody would like to photograph it, perhaps. So that's an interesting point, which we'll come to in just a moment. So this is very important because it's the opposite of what NICE said. Human progesterone and diprogesterone have no excess risk of breast cancer, and any type of HRT probably diminishes neurodegenerative disease, which is what I've now got to prove to you. Now, it's interesting, it's quite difficult to tease out the difference between cognition, sleep and mood, because they're all associated with each other, as indeed are vasomotor effects. So let's see how we can put these in a slightly better way. There is a standard narrative to how all this lot works or fails to work. So let's look into it in a bit more detail. The narrative is, and this is wrong, that the hot flushes cause insomnia. Insomnia, therefore, causes brain fog because you're knackered, and therefore you become anxious, which causes palpitations. Oh, and by the way, you get arthralgia anyway, but who knows what that's all about, because it doesn't seem to be linked at all. But if you put all this lot together, if you've got arthralgia, anxiety and brain fog, then you're bound to get reactive depression, and you'll see a psychiatrist who will diagnose you with endogenous depression and give you all sorts of different medication, or a GP who will give you SSRIs, which are contraindicated under these circumstances, according to the original NICE guidance from 2015. So let's just continue with the imagery here. This is the South American imagery, and I put this up there. There was he's Colombian. He's given so much pleasure to so many people in South America and all across the world, and he died only a month before I gave the lecture, so I thought I'd put his image up there. And also remember, of course, that the more depression you have and the more PTSD you have, the more anxiety you have and the more brain fog you have, and the more it affects your neuroplasticity. So there's a lot of things going on here, and they're not all, they all seem to impinge upon each other in lots of different ways. But the most interesting thing, of course, is that estrogen has a direct effect on each of these issues, rather than them just interacting with each other. For instance, estrogen has a direct effect on insomnia. It significantly increases the amount of deep non-REM sleep that you have, which means that that's the restorative sleep that everybody needs. So women, when they're put onto estrogen, by and large will sleep better, longer. Remember, for those who are not taking it, they might sleep the night, but they tend to wake unrefreshed, and that will trigger all the other different things. But remember, of course, that estrogen affects all the other issues here. As far as cognition is concerned, estrogen has a direct effect on cognition, probably larger for all sorts of different ways. It affects on neurotransmitters, it affects on microvascular atheroma, and all, as a long-term effect. But there's also something quite interesting here that's going on at the same time, is that testosterone probably has an effect, although that's not, sure we don't say loud. It might improve the image of the woman, and improve her tissues, and improve all sorts of things about her. But if we think also that estrogen improves the flushes, and the worse your hot flushes are, that also has a direct effect on cognition, because it's a neurovascular activity. So all of these things are linked, and you can't just put them into different boxes. It all goes together. So the more severe your vasomotor symptoms are, the poorer your cognition will be. So that shouldn't be there. Okay, so if we now put all this lot together, what's going to happen if you do some random polypharmacy on our Mona Lisa here? You might give her some treatment for insomnia, some treatment when you can't treat a brain fog. Hopefully, if you get a bit more sleep, if you give her some drugs to make her sleep, give her some anxiolytics to improve her low mood. But remember, NICE comes up with a very interesting statement: don't use SSRIs or SNRIs to alleviate low mood in menopausal women who have not been formally diagnosed with depression. And once again, we don't need any of these drugs if we start thinking seriously about using HRT. Okay, so we put all that up together. Can I prove to you, or can we accept perhaps that there may be an association of long-term HRT, or as the Americans would call it, menopausal hormone therapy, which means HRT started early, or started at an appropriate time on neurodegenerative diseases. And this is an enormous piece of work from Roberta Brinton's group, and I'm going to take you through this by just looking at a few bits and cutting them together to make the slide understandable. So this is how we put it together. All our neurodegenerative diseases are down here, and also the specific individual ones. And what's interesting about this is that the risks are very substantially reduced for all of these, and also the confidence limits are very, very tight indeed. Just look at that, how tight those confidence limits are. Now, this is a retrospective study using insurance data, and of course the insurers actually know who's taking what treatment, because they're responsible for paying for this stuff. They don't really want to pay for it, but they have paid for it, and so they do know exactly not only what conditions these people are getting, because it costs the insurer to pay for those conditions, but also what drugs they're using. Let's have a little look at the specific effect on Alzheimer's from the various different treatments. And they're variable, but basically by and large the estrogen only, the human estrogen, 17-beta estradiol, performs better than conjugated equine estrogen. But even so, the rubbish stuff, or stuff that we would consider less than totally optimal, perhaps a more polite way of saying it, the conjugated equine estrogen also substantially reduces Alzheimer's disease. So that's actually, once again, quite an interesting phenomenon. So why is this so? Well, what they found is that these are the key findings from this paper. MHT, once again, HRT started within 5 years of onset of symptoms, reduces Alzheimer's and other neurodegenerative disease risks, so start early. I think everybody's finally got the message, start early. Also, the risk reduction becomes apparent around the age of 65 and above, so just keep going. And in fact, you get a better risk reduction the longer you stay on HRT, or menopausal hormone treatment. It's interesting that the transdermals seem to do better than the oral regimes, and estradiol, 70-beta estradiol outperforms equine estrogen, but they still do pretty well. That's still quite a substantial reduction. So what's the mechanism? Well, I had actually changed this slide to I've just given the game away, of course. I think the next slide is what the slide should have looked like if I'd actually removed it. So let's just come back to this excellent study, looking at the fact that we know that if you treat hypertension, you reduce the risk of Alzheimer's. We also know that if you control diabetes well, it also reduces Alzheimer's and dementia. And of course, once again, the mechanism is exactly the same of preventing microvascular atheroma. So it's logical, because you're doing that in the heart, you're doing it in other tissues, and it's happening in the brain. So the sooner you start, the better. Oh, and what does NICE say? Don't offer HRT for the purpose of dementia prevention. Well, that's interesting. Now, once again, the NICE data is all based on prospective randomized trials, none of which are going to be long enough to show an effect. There isn't ever going to be a randomized trial that will be long enough to show that effect. So the only way that they can find the information is A, retrospective data, and biological plausibility, because we've actually got a biologically plausible mechanism by which the treatment works. Okay, so that's another thing from NICE that's in the bin as far as I'm concerned. So just to summarize, each of them produce cognition, improves sleep, improves mood, probably reduces suicide in perimenopausal and newly menopausal women, because remember those ages 45 to 49, 50 to 54 are the highest risk for suicidal ideation, suicidal attempt, and actual death from suicide. And so almost certainly this stuff would have a benefit for that group of women. Those are the various different references. So taking everything together, we're nearly done now. We've rather rushed through this, because we could have talked at length about almost any of these slides and the detail that's in them. And once again, I'm not a metabolic specialist, but you could have a lecture on that. You could, I could certainly give you a lecture on dyspareunia, incontinence and UTIs, and inappropriate treatment for thrush instead of vulvovaginal atrophy. And once again, there are some brilliant experts who will teach you an awful lot about osteoporosis and osteopenia and how to treat it, how to investigate it. But remember that the best treatment and prevention for osteopenia and osteoporosis is estrogen started early. And even the lowest dose of estrogen will work. There's an American study showing that 14 micrograms of estradiol in a patch, unopposed, has no effect on the endometrium, but has a very substantial reduction in osteoporosis and osteopenia. Sorry, I haven't got the reference up because I had a bit of extra time. I thought I'd mention that just for the fun of it. So, where do we go with that? Oh yes, so we're coming to the end. This was a statement from Roger Lobo's consensus group, going back to the future. HRT should be considered as part of a general prevention strategy for women at the onset of menopause. And my particular way of looking at it is transdermal is not oral estrogen, human not synthetic progesterone, and individualized estrogen dose. Also, once again, at the bottom line here is don't just treat each symptom, treat the cause of the symptoms. Now, isn't that a normally relevant way of making a medical point? But to put it even shorter, basically start early, keep going, and for God's sake, don't stop. Why would you want to stop treatment? And another final punchline perhaps is this: prevention is better than polypharmacy. Now, I say prevention is better than cure. You can't cure everything, but certainly the polypharmacy that is currently going on at the moment, which seems to be nice policy, could be improved upon, I would very politely suggest to you. So remember that in terms of the overview of this, there's the inappropriate research interpretation, as offered by the MHRA for the previous 20 years, the lowest dose for the shortest time, stop when you're 60, no more than 5 years. All of that stuff is complete and utter rubbish and has been shown to be so. So my particular statement to undo the damage of the last 20, 23 years or so is quite simply as much as you need for as long as you live. Thank you very much indeed. Just a minute, can you just go back? I've just got a couple of other things to put up for you to browse over. So that was a couple of things about the nicer. Oh yes, and we got nicer than nice. And finally, just to show you that we're on board with our colleagues across the channel. This was yesterday in Paris, and it's the THM, of course, is thérapie hormonale menopausal. So it's a rather nice little pun that they're using there. So at 45 years, you should make a consultation with women to consider the risks in that decade, screen for the risks, propose effective treatments to diminish the risk of cancer, which we've shown you, to diminish cardiovascular risks, and also proposed effective treatments to improve the quality of medico-psychosocial life and sexual life, and treat the troubles of the cycle and of the atrophy and climacteric syndrome. And also, maybe you might be able to prevent some cognitive symptoms. So the French once again are on board in exactly the same way. Thank you very much.
Well, a masterclass, of course, in so many ways, Peter, particularly preparation of presentations, just extraordinary, and thank you.
My pleasure.